All right, my name's Drew Bachman, and in this presentation, I'm going through my injury history throughout my baseball career as a left-handed pitcher. This was kind of inspired and brought on by Josh Elman, who's kind of introduced me to this whole world. And throughout this presentation, I'm going to be using concepts and ideas from Posture Restoration Institute, PRI, Bill Hartman, and Connor Harris. So if you're not familiar with their work, a lot of this stuff might seem pretty foreign and different, but I'm going to try to do my best to explain it the best that I can and make it as simple as possible. But at the same time, I'm not an expert, so there's some things that I say that may not, something sounds a little off or you disagree with anything, please let me know. I'm always open to learning and discussing things further. I do anticipate this video being pretty long, so I plan on splitting these up into sections throughout the videos just to make things a little bit easier. So going through this list here, overview of my history, it'll just go through pretty much every injury that I missed time with throughout my baseball career, then examining structural factors and predispositions, things like infrasternal angle when I'm biased towards, a deeper dive into my shoulder impingement and the solution to that, and then a deeper dive into UCL sprains and the eventual tear and possible solutions to that. Then looking specifically into my mechanics, some of the inefficiencies that may have contributed to my injuries as well, and then what I would do differently. All right, so to start the overview of my injury history, got to go all the way back to 5th grade at 11 years old. Some general arm pain and soreness in the shoulder and bicep area. Nothing really too pinpoint, just kind of that widespread tendonitis kind of like feeling. And then moving along to 15, had some thoracic outlet kind of symptoms in my neck, had some tingling that would go down. It would start around the scalene area and kind of creep its way into my shoulder. Missed a couple months with that. It was kind of the tail end of my summer baseball season, so it ended up working out because I had a little break in the fall there, and things kind of felt better from that aspect when I started throwing again. And then probably about 5 to 6 months after that, some anterior shoulder pain and bicep pain. And the bicep pain was kind of something that never really fully went away. It was something that I would have to manage throughout my career, basically. The anterior shoulder pain was better after I did some shoulder strengthening stuff and stuff in that realm. But all right, so summer 2019, this is the summer after sophomore year of high school, going into junior year, had my first UCL sprain. This put me down for about 3 months. During those 3 months, was pretty much just trying to gain weight. Did a lot of traditional physical therapy, shoulder strengthening stuff. That's at the time what I thought was going to prevent future injury. And then as I started throwing again, immediately, pretty much right away, had a lot of pinching in my shoulder. And anytime I went back into layback, a lot of pain, pretty much made it impossible to throw. This is me kind of working through it. This is during COVID. You can see this pussy arm action here. This pretty much lasted all the way to the fall of 2020. I actually had a posterior capsule release surgery, and I believe the end of July of 2020, which really didn't do too much. It may have helped a little bit, but there's something that I'll touch on later in the presentation that really was the solution. And then moving along with senior year, 18 years old, had my second UCL sprain at that time, kind of the same type of feeling as this one. Maybe not as bad. It didn't swell up as much as this one, but still put me out for about 6 weeks, and then happened again in April. That one only really put me down for a couple weeks. That one was a lot less severe, just kind of like more of a tweak type of sprain, but just one of those things that kind of kept reoccurring. Moving into the fall of 2021, that previous UCL injury was something that lingered throughout the summer and into the beginning stages of fall ball. Kind of one of those things that would flare up on me from time to time, and I just had to manage. Then I started having some pretty intense bicep pain towards the end of the fall and into October. Started to get a little better, then came back as I started to ramp up. And then got an MRI in January because the pain was pretty intense and it was pretty deep and really achy type of pain. Ended up being like a humerus stress fracture, so that made a lot of sense with my symptoms. That put me out. Initially, it's supposed to be 8 weeks. Was on the ramp up, was doing well on the ramp up. Then around week 3 or 4, kind of the same type of pain again. So that sent me back another couple months. Really wasn't 100% healthy from that until July. So it put me out for a good amount of time. And then moving into the fall of 2022, had a partial UCL tear. This is my second bullpen in the fall. And one of those things was kind of weird. It wasn't like a pop or anything like that. Obviously not with the partial. It wasn't even really a one pitch type of thing. It was more after I was done throwing and I was kind of moving my arm around. And anytime my hand got outside of my elbow, get in the frame here. It was intense pain, and it really like kind of right away knew that it was worse than my previous sprain. So obviously the fear was that it was torn, and it got confirmed with an MRI a couple weeks later. I ended up not having the repair and internal brace until March. Pretty much tried every conservative option in the book, physical therapy, resting it, stuff like that. Tried a PRP shot in December. Pretty much no dice on anything that gave me like long-lasting relief from my symptoms. I was still able to throw at pretty light intent without any pain, but anytime I feel like I got above like 60 or 70% intensity, it'd come right back. So looking at physical structure here, just some physical characteristics. When it comes in infrasternal angle, I'm more towards the middle of the spectrum, but I would say slightly towards the narrow end, sort of the angle if you're not familiar with it. It's underneath the xiphoid process, but technically if you're measuring it, it's kind of these lower ribs here. You start the measurement around here. You're not really measuring the exact degrees. It's kind of you're kind of just getting an idea where somebody's at, where they exist in that continuum. That'll give you a basic idea how they produce force and internal pressures within their body. I'll go into more depth on that. I believe it's the next slide. And then moving along, the pectus excavatum, kind of that depressed sternum. See that indentation of the chest wall here. Mine's similar to this picture. I try to find someone that was around the same degree. My indentation is a little bit larger on the left, but very similar to this image here. And then the wing scapula, I have it on both scapulas, not just the left like in this image. But sort of that wing appearance of the scapula like popping off the rib cage. Also something that I'll touch on in future slides. But these are just kind of going over a brief introduction into some defining physical characteristics. So to go deeper on the infrasternal angle, with a narrow infrasternal angle, we have an axial skeleton that's biased towards inhalation with a relatively descended diaphragm. So if you look at the ribs here, with the descended diaphragm and inhalation bias, in order to create an exhalation strategy, these ribs have to close their angle, so they have to appear more narrow, more internal rotation of these lower ribs in order to create an exhale. So since we're starting from that inhaled position in order to create that exhale, that's why we have this physical representation of the more narrow angle here. With that, we're also going to have an anterior compression. So we got compression from the front side, opens up this back side relative to the front. This is going to bias us more towards external rotation with the narrow infrasternal angle. So things like shoulder and hip ER, shoulder and hip flexion and abduction will be increased relative to the internal rotation measures. Now obviously with secondary compensations, those measures would change, which pretty much everybody has some layers of compensation, so it's not always going to be that the ER measures are greater than the IR measures, but from the starting position, that's how it starts off. And this is kind of like a physical example. Jacob deGrom's kind of like the poster boy for a narrow pitcher, super narrow, not super pressurized, isn't creating absurd amounts of force, but he's applying those forces over a long range of time. He's able to access extreme degrees of external rotation throughout his delivery within his shoulder and hips and stuff like that. So that's kind of just an example, a visual example of kind of the things that we're talking about here. So taking concepts from the last side with a narrow infrasternal angle and that anterior compression, then adding in this pectus excavatum component where we have the depression, the actual like bony depression of the sternum. So there's already like the indentation, that depression of the sternum bone. That's going to bring these upper called pump handle ribs, the ribs that have a fixed attachment point to the sternum here, that are more, they expand more anterior to posteriorly as opposed to laterally like these lower bucket handle ribs. So when that pump handle comes down even more, we have a sternum that's really depressed, so it's going to bring these ribs down even more, even though they're already anteriorly compressed from just that initial bias with having the narrow infrasternal angle. And then what happens there is when we have this internal rotation occurring at these upper pump handle ribs, the scapula is going to come along for the ride with it. So the scapula is going to go into more internal rotation. So we're going to see this medial border of the scapula kind of come off that rib cage, and that's what's going to give this wing appearance. So when we combine all these aspects, the already being anteriorly compressed, having that bias with the narrow infrasternal angle, the depression of the sternum through the pectus excavatum, bringing these pump handle ribs down even more, that's going to bring this scapula kind of off the rib cage because it's going to be in more internal rotation. kind of giving that wing appearance. So before I expand further on the pectus excavatum and its influence on my structure, I wanted to first go over some basic things about pressure and pressure gradients. So in this image here, we have the inverse relationship between pressure and volume. So we have this piston come down, decreasing the pressure and decreasing the volume and increasing the pressure relative to this image. We have a higher volume and lower pressure. Then just a basic depiction of pressure gradients. We have things flowing from high pressure to low pressure. This will be illustrated in the next slide when it comes to the direction of airflow in relation to the pectus excavatum and its structural influence. So take the concepts on the last slide and apply them to this image here. So with the depression of the sternum here with pectus, so we have a decreased volume in this upper portion due to this indentation, this depression here. Decreased volume, so increased pressure in this upper portion. In relation to the lower portion here, we see increased volume and decreased pressure. So this is going to redirect air downwards. There's going to be a lot more air in this lower portion as compared to the upper. So in order to change the situation, we need to recruit muscles that are going to internally rotate and decrease that volume. Down here, the lower rib cage, so things like internal oblique, transverse abdominis, and external oblique as well. So to kind of illustrate what would happen after the facilitation of those muscles, so we have like compression coming here from the internal rotation, decreasing that volume of the lower rib cage, lower thorax. So we have decreased volume now and increased pressure of this lower portion in relation to the upper portion, so increased volume, decreased pressure, so it's going to redirect air upwards. So with the depressed sternum, the threshold to redirect air upwards into the upper parts of the thorax is increased due to the initial pressure gradient that we saw in this image here. So this illustrates the need for the need to facilitate the internal oblique, transverse abdominis, and those muscles that internally rotate the rib cage, because without them, there'll be a lot of air trapped in this lower portion of the thorax, lower portion of the ribs. And this air is going to be unable to travel upwards. So we're going to see a lot of like rib flare, the widening out of this angle just because the amount of air that's trapped in this lower portion of the rib cage. And something that I forgot to mention in the previous slide, when we have that situation where air is not able to expand in the anterior chest wall, we're going to see a decrease in internal rotation measures of the shoulder. So kind of along those lines, an additional structural adaptation that we're going to see is the retroversion of the throwing shoulder. So this is going to increase external rotation. This is something that's pretty advantageous for performance, to have that increase in external rotation, be able to get more layback of the throwing arm. So this is kind of illustrated in this image here. We have this twisting occurring at the neck of the humerus, where the head of the humerus is kind of tilting back. So this axis drawn here for the neck, and then through the humeral head, and then this degree here is kind of the degree of retroversion when it comes to humeral retroversion. So like I said, we're going to see further decreases of IR in the shoulder, and then the implications of a humerus oriented in ER, something that we're going to talk about a little bit later in regards to my elbow history and injury. But this is an adaptation that's kind of a necessary evil. It could bring about some, potential injury issues, but it's something that you need in order to throw hard. So it's kind of one of those things where it's a double-edged sword. So now going into specific injuries, we're going to start with the shoulder impingement and just some kind of context around this time period, kind of where we are throughout my career. So this is going into my junior year of high school. This was right after my first UCL sprain, which was in June. Had about 3 months off from throwing, and during this time did a lot of heavy lifting, try to gain as much weight as possible. The thing that really got me from, or at least in my mind, what got me from the low 80s to the upper 80s during this time period, kind of during that freshman to sophomore year of high school, was just gaining weight. Went from about 160 pounds to 185, 190, and that was mostly just through heavy lifting and just trying to stuff my face with food. Then I pretty much took that approach and tried to just push it even further. Kind of when I got hurt, so I really ramped up the lifting, ramped up the eating, got to about 205, a little bit north of 205 pounds, and got a lot stronger in these three main compound lifts. Because I figured, all right, well, I went from the low 80s to the upper 80s by getting stronger, gaining weight. The thing that's going to take me to the upper 80s to the low 90s, mid 90s is going to be something along the same lines. And obviously that was not the case. So the heavy bilateral lifting implications. So with these lifts, basically what I was doing was compressing myself front to back. So we already had that anterior compression that we talked about with the narrow infrasternal angle, the down pump handle with the pectus. And now basically what I was doing is I was compressing the backside as well. So these are all very compressive lifts in nature. They're bilateral, so you're squeezing both sides of your body at a time. So you're not allowing any type of turn. There's no compression or expansion on either side. You're just compressing both, and there's really nowhere for you to go. They're just kind of trapped. They're really good at like creating stiffness and orientation. So they do have a place. Like if you're just trying to build a base of strength, it's not to say that they should never be used. There's just kind of a time and a place. And I kind of used it to build that base layer of strength, which was advantageous up to a certain point. But then after a while, it started to steal my range of motion big time. Yeah, so basically it was squishing me front to back, stealing my range of motion, and during this time I wasn't throwing, so there's really no way to check like, wow, what am I doing in the weight room actually like translating to throwing? Because I was 3 months off of throwing, so I was just crushed in the weight room, and I was like, oh, by the time I get back to throwing, I'm gonna be throwing so hard because I'm so much stronger now, I'm so much bigger. But that was not the reality. When I got back to throwing, it was immediately like, oh my gosh, my body is unbelievably tight. Then on top of that, the traditional rehab approach with the UCL sprain consisted a lot of like rotator cuff strengthening, scapular strengthening, a lot of stuff like this, ISTs and Ys, where we were compressing the backside, trying to strengthen the muscles around the scapula, rotator cuff, stuff like that. Which at the time made sense. Figured if that stuff's weak, then the elbow's gonna have to take a lot of the stress. But although I might have needed some of that, I pushed a little bit too hard because I figured more is better in that regard. When that was not necessarily the case. What I was really doing was contributing to that squeeze front to back, and now I have a backside, a posterior that's compressed as well as the anterior, so I'm kind of flattened like a pancake, and I really don't have much movement at all now. I already had limited internal rotation in my shoulder, and now the external is very limited. Not a good combination. Something I want to make clear about the previous slide as well is that I want to be clear that I'm not saying that there's no place for heavy bilateral lifting like trap bar deadlifting, benching, squatting. I absolutely do think there's a place for that. I'm just saying I think we need to be aware of some of the negative consequences as well, and be able to see that. So with that said, so kind of moving into some of the stuff I already talked about in the previous slides. So you have that posterior compression on top of the anterior compression here. So you have that down pump handle. This arrow is kind of representing that compression. Then we also have the compression on the backside now. That's kind of come through the physical therapy exercises, a lot of the squeezing of the shoulder blades down and back, try to strengthen all the stuff around the scapula, those types of things. And then kind of a great thing you can kind of test on yourself to kind of feel this is you can press yourself in the front. So press yourself in the front of the sternum, kind of press in there, and then pull your scaps together and watch how you literally move forward into space. This is kind of contributing to that anterior orientation that I'm talking about here. You can kind of see the pelvis tip forward, and then anterior pelvic tilt. Again, not necessarily a bad thing. You can have an anterior pelvic tilt and still be healthy and all those things, but it's just something to take note of here. And then the loss of shoulder external rotation on top of the IR, that's something that I touched on the previous slide as well. That's what happens when we're compressed front to back. There's really nowhere for air to go. We kind of lose range of motion in both directions. And then loss of rotational capabilities, starting to move really as one piece, just due to the kind of the influences that I put on my body through the lifting. Although a lot of those things were moving through orientation, moving stuff together, squeezing two things together, not being able to dissociate and create a turn, which is what I would need during a throw. All right, so we kind of put things together from the last two slides and do like a visual example. This is me throwing at the end of January. This is about already trying to ramp up for about a month with pretty much no progress and symptoms. Pretty pinpoint pain at the top of the shoulder. Anytime I would get into any type of external rotation or layback or try to get into layback, there's really not much of it going on. So we'll kind of run through this here. And you can see there's really no type of dissociation between the upper and lower half, or really any joints for that matter. Arms extremely pushy, not really moving through any type of actual range of motion with the arm. So this is what I've been talking about, being pushed front to back. There's really nowhere for me to go, so I'm kind of moving, just turning my whole body as one piece, arms just coming along for the ride. There's no type of dissociation, no type of whippiness happening, and it was extremely painful as well. To go a little deeper into the video, I'm not a huge fan of using still frames, but I do think they illustrate my point pretty well here. So here's that like front foot plant. This is when weight is into my front foot. You can see an inability to dissociate upper and lower halves. The hips are still pretty much completely closed with the upper body. The arm is very, very late. It's probably like 0 degrees to 5 degrees of ER, a flip up. And then here's layback here, maybe around 130. Still very limited. And then you can see going into release, the arm has to climb way above the plane of the shoulders. So it has to go way up because it really doesn't have the true range of motion to be able to work through actual external rotation. It has to climb up in order to get there. And it's also just indicative of me being really, really compressed on that backside. There's really nowhere for that scapula to move. And something that I didn't talk about on the previous slide with posterior compression, a lot of those like squeezing the scapula type of exercises, when they're taken to the extreme, and all you're doing is downwardly rotating and retracting the scapula, it really just ties down the scapula. It doesn't allow it to upwardly rotate and posteriorly tilt, which is really what it needs during the throw. And obviously, I think it can get those exercises still have value, but when those are the only things that you're doing, and you're really getting really strong in those muscles, and they're really pressing that scap up against the rib cage, but it's not really allowing freedom of motion within that scapula, you can kind of see that manifest itself in these 3 images in that video. Before I go into the solution of my shoulder impingement, I want to give some more context kind of around this time period. So that last video was taken January of 2020, the one we just examined, and then kind of through that time, this is kind of when COVID hit, but through COVID, I was working a lot with Josh Ellman. He helped me a ton getting range of motion back, and I was able to pitch a little bit in that summer for a couple of starts, but still was not able to let go at all. Like, felt like I was constantly guarding against that impingement. Wasn't able to be loose, and certain days it was still really bad. It would kind of come and go a little bit. It wasn't as constant, but one of those things that I knew it still needed to be fixed before I could move forward. So I go to the doctor again in July here, and this is probably my 3rd time seeing them this year. And at this point, they're like, we'll give you the option to be able to do a posterior capsule release. This is kind of what they recommended. They said, well, you're really tight in internal rotation of the shoulder, and we think it's because that posterior capsule shoulder is really tight and fibrotic after, from throwing, so we can go ahead and release that. Pretty minor procedure, will only be a month of downtime. I went ahead and agreed because that made sense to me at the time. Looking back on it, probably didn't really make much of a difference. It was really just like a forced rest, and then I really didn't get relief from my symptoms until I saw Bill Hartman at IFAST physical therapy in September, but did a lot of physical therapy after this surgery, and like I said, still had symptoms afterwards. It was the same, if not a little bit worse, honestly. I didn't throw yet, so I wasn't really sure how it felt throwing wise, but just kind of moving it around really did not feel any better at all. So I see Bill at IFAST in Indianapolis in September, giving a series of exercises, and within that same visit, so he would kind of check my ranges of motion after each exercise, and after each one, I noticed I would gain range of motion, and not only gain range of motion, but everything just felt looser and cleaner, and I was like, oh my gosh, this is like what I've been looking for. This is definitely the answer. So after a couple weeks of that physical therapy and another follow-up visit with him, started throwing in October, and this is me my first day throwing. This is doing some type of pivot pickoff variation, but you can kind of see here just the extreme levels of range of motion that I gained literally from 2 weeks of exercises with Bill. This is kind of what I had underneath all the layers of compensation. I just kind of had to strip away at those layers of compensations that I built up through the heavy lifting and some of the physical therapy exercises. I was always capable of this position. I just kind of lost it after kind of layering on some compression. So this was in October, and this was pain-free, felt super loose, felt great. So yeah, pretty much that was my progression through the shoulder impingement. I'll go into more specifics about the solution in the next slide. First thing I wanted to touch on when it comes to the specifics here is what a lot of people coin as the stack, and it's basically the stacking of the pelvic diaphragm here with the thoracic diaphragm. So this is kind of the poor example of what you don't want. This kind of looks very similar to me a couple slides ago with that picture of me reaching towards the wall, that kind of side view. So you have your center mass push forward into space, the anterior pelvic tilt, and then the ribs flare upwards. So you're literally pushed forward into space, that anterior orientation. Then once you kind of bring things back, you're able to line up pelvic diaphragm with the thoracic diaphragm, and they're able to work together to manage pressure a lot more efficiently within your body. So they're able to properly descend and ascend together. That's going to be able to promote this 360-degree expansion to the thorax that we need here. So we're able to, in order to get this, we need to accomplish this first. So without the stack, we're not going to be able to properly get this global expansion of the rib cage. We're not going to be able to get this posterior expansion that we had lost before, as well as a little bit of anterior expansion as well. There's just a lot more space to expand into in this posterior region, and then as well as eliminating interference. So Bill made it clear to me that I was in a spot where I'd been compressed for so long that I needed some time to get away from those heavy bilateral lifts. So I went about a couple months where my only lifting was unilateral lifts. So I wasn't allowed to do anything with a barbell. Everything was just focused on kind of recapturing that range of motion that I had lost. And that did work. I was able to rapidly gain range of motion. I just kind of wish I had transitioned into a little more power stuff. I feel like I lost a little bit of power, but I was able to gain the range of motion and be pain free, and that was the focus of the time. So that definitely worked out. All right, going to more specifics. The first exercise, this is the very first exercise that Bill gave me. The right sideline left adductor pullback with the left reach. This is an absolutely money exercise for me in particular. This is a really common PRI exercise, I think, for good reason. I think it does a lot of really good stuff. I can make a whole video just on this exercise in itself, but just to go over a couple brief things. Sideline position, so we're going to have lateral compression that's going to promote anterior to posterior expansion of the thorax, which is something that I need, so I'm able to get air into the backside of the rib cage. With that reaching long with that left arm, promoting so air pushing in through the front and expanding through the back. It's also going to shift my center of mass back, and something crucial in this exercise, along with all the other ones too, is getting my pelvis under me, stacked underneath me. That was step number one, which was really hard for me to feel because I'd never felt that before. I'm so used to being so extended all the time that was probably the hardest thing to do throughout the whole visit. And then kind of this next one here, inverted quadruped, breathing on elbows. Pretty simple and basic here. Really worked well for me because this is really low tone. Like I don't have to use any pecs or shoulders to really support myself. I'm kind of just resting on my elbows. And we're using gravity to assist us in getting air into this upper quadrant of the thorax, because gravity is kind of pushing air down this way. And then kind of progressing again, the standing wall supported reach. So basically being able to maintain these positions under the influence of gravity now that we're upright. So if I had started with something like this, it may not have been as successful, probably would have been a little bit too much too early. Had to kind of get those base feels through these sideline drills, this prone drill, and then be able to progress it to an upright drill. So this is doing a lot of really good things here though. So we're shifting our center of mass back by reaching long. We're feeling ourselves sit heavy into the heels here. That low back flush up against the wall, scooping the pelvis under us to stay stacked with those the pelvic and thoracic diaphragm. Like I said, reaching long, and that's going to promote the expansion of the backside, just like these other three here. These weren't the only three exercises that he gave me. Probably had a total of 6 to 7 between the two visits. I just feel like these three were the most effective, and were fairly easy to explain as well. So I would do 5 sets of 5 of each of these a day. So breathing in through the nose, out through the mouth. Again, could go into another separate video on the breathing component of these exercises, but I would do that at least once a day, sometimes twice a day. So it would take a good amount of time. I'd say one session of like 3 exercises would take 20 to 30 minutes, but it was well worth it. I could see the results, like I said, right away. So these were my big 3. Again, these are very individualized based on your structure. So these 3, just because they worked great for me, might not work for somebody else. Yeah, so moving along to, I think the next slide is the UCL history and the eventual tear. All right, so diving into the elbow history, we're going to start from a zoomed out perspective. So we're going to look at this kind of globally. We're going to look at the whole body first and then kind of zoom into the elbow specifically. So this is where I'm going to start to get into some PRI type of terminology and stuff. So if you're not familiar with PRI, stuff might be kind of new. I'm going to try to explain pretty surface level with a couple of these terms. So with this image here, kind of a visual representation of the left AIC, right BC pattern. So left AIC, left anterior chain. So I wish I had my pelvis model, but we're going to be, the sacrum is going to be turning to the right. It's going to be oriented to the right. And the left innominate is going to be pushed forward in an external rotation, abducted, and flexion. So it's going to be tipped forward. Then the right innominate is going to be the opposite of that. It's going to be posterior tilted. It's going to be extended, internally rotated, and adducted. So it's going to have a lot of different influences kind of on our pelvic mechanics. Can make a whole video on that, but essentially that's the way we're wired beneath the diaphragm. Then above that, at the diaphragm, the right diaphragm is a lot larger than the left. It's also in a more respiratory position because it has the liver under it, kind of acting as like a piston, so it's able to ascend a lot easier. It's kind of resting in a more ascended position. Then the left it's literally physically smaller, and it's more flattened out with the heart above it. So it's in a more postural in a more postural position. It's more of a postural landmark type of position. So with that said, that has a couple of implications. So with that left diaphragm being in a disadvantageous position, both mechanically and structurally, we're not able to pump air into the right chest wall as easily as the left. So the right chest wall is going to be limited in what's called apical expansion, so the ability for air to travel up and then also out. So with that, and then the other thing with the right BC pattern is it's kind of reacting to what's happening beneath it. So we have the pelvis underneath it oriented to the right, the sacrum's oriented to the right. So the left ribs are going to externally rotate with the right ribs going into internal rotation. So it's kind of counteracting what's happening underneath it with those left ribs coming up, right ribs coming in. That's why we usually have a larger rib hump on our left side. That also comes with some implications as well, but you kind of see that visually here at the right BC pattern. We see this left shoulder slightly higher than the right, which is different because you would think most people, their throwing shoulder is a little bit lower than their non-throwing shoulder, but obviously in this case it's not. And then kind of underneath that, with the descended left pelvic floor, kind of that right innominate slightly above the left here. And we also see that right thoracic side bend here. So if I were to draw a line kind of straight on through, you can see I deviate a little bit to the right. This is really shown well kind of on the side of my body here. You can really see the bend happening through here. This is a little bit straighter on this left side here, and you can see more of a lateral side bend to my right side. Again, goes right along with the right BC pattern. In this image here, it kind of shows the pattern throughout the body, how things kind of react in accordance to what's happening, kind of proximally to it. But this has other implications that I'm going to touch on. I believe in the next slide is going to go over more locally what's happening at the elbow, and then we're going to start talking about relating to mechanics and stuff like that. So we're going to circle back to all these concepts that I kind of touched on throughout here. Try to keep it relatively surface level. Could dive way deeper into some of this stuff and its implications, but for now, for the sake of this video length, it's already going to be pretty long, but I wanted to just give a brief kind of overview just to provide some context for the stuff that we're going to be talking about later on. So still in the zoomed out perspective here, this diagram here does a great job depicting what I was talking about, the left AIC, right BC pattern. Up top, we kind of ignore this for now. That's more for the superior T4, which I'll touch on in a second. But underneath here on the bottom half, we have the left innominate push forward into external rotation as well, or the sacrum oriented to the right innominate and extension, posterior orientation, and internal rotation, and also this lumbar spine oriented to the right. The thoracic diaphragm literally attaches 3 to 4 inches lower on the right than the left, so that's literally pulling this lumbar spine to the right even further. And then kind of going into up top here, so that the scapula, the left scapula is going to be in more external rotation relative to the right, so it's going to be pinned up against that rib cage. It's going to bring that humerus into more external rotation. So as we're throwing, this is kind of something that happens already as an adaptation to throwing, but structurally this is kind of how we were already set up with the right BC pattern. So that scap's already kind of pinned up against that rib cage. So when we further increase that throughout throwing, we're trying to create more and more external rotation. That you could run into some issues because you're kind of pushing it a little bit too far. And also we'll go into the implications of that humerus having too much external rotation in the next slide. So something else I wanted to touch on would be superior T4 syndrome. So another reason why the internal rotation on my left side would be decreased, because in the normal pattern, so we would have the right ribs being an internal rotation, left ribs an external rotation. This would provide apical expansion on the left side, which would in turn create internal rotation on the left. So you would have a deficit in right IR, not left. But my left IR was just as bad, if not worse at times, than the right. And this could be in part due to superior T4 syndrome, which is where above the vertebrae T4, excuse me, the ribs kind of flip orientation here. So you see these lower ribs, these lower left ribs, and external rotation here, which goes along with the right BC pattern. Then you see it kind of flip above T4. So the sternum still oriented to the right, but these right upper ribs are in more external rotation now. This is happening through kind of the right SCM, the right scalene. So they're kind of picking up for the slack of this left diaphragm not really doing its job properly. This left diaphragm isn't doing a great job of pumping air into this right chest wall. So the right SCM, right scalenes are like, all right, we'll do the job for you. And they're literally pulling up these right ribs to get air into that chest wall, which is why you could have more right IR than the left. And then increased demand on the ear for performance, retroversion of the humerus. That's something that I kind of talked about over here and touched on with the part on structure, but that also contributed to the decreased IR of the shoulder. It could just be that twist of the humerus, the humeral retroversion that's causing that decrease in the IR, along with some degree of superior T4. So to finally zoom into the elbow itself, we're going to look at the valgus carrying angle and what that represents. So we're kind of look at this angle, which is like the axis of the humerus, the axis of the forearm, and then that carrying angle in between, usually anywhere from like 15 to 25 degrees, a little bit higher if you're a thrower, just because of those increased demands of throwing. And it is an advantageous adaptation when it comes to performance. But we'll talk about the some of the other consequences as well. So what it represents. So if you kind of look at this in a 2D perspective, kind of on a frontal plane perspective, you would just think that, okay, the humerus is in more internal rotation, you could say pronation, and then the forearm's in more external rotation or supination relative to the humerus. But when we start looking at this at 3 planes, it's actually not the case. And this is something that I got from Mike Camperini and Mike K and their Substack called Context Driven. So all the credit goes to them on this slide. This is something that made a lot of sense as I was reading it. So we kind of look at a depiction here. Now I'm using 2-dimensional arrows to represent something that's happening in 3 dimensions, so not the best, but couldn't find any ways to make a 3-dimensional arrow here, so we're going to have to stick through it and try to visualize the best we can here. So this is a posterior view of the left elbow, and so what we have occurring here is distal humeral ER relative to the forearm. So this humerus is turning outwards into external rotation. The distal part of the humerus, that is an external rotation relative to the forearm here. The forearm's doing just the opposite. So it's in relative internal rotation approximately relative to the humerus. So with this twist that's occurring, we're going to see an increased gapping occur at the medial side of the elbow and approximation or compression at the lateral side. So these 2 bones are getting closer, and then you have the medial epicondyle with the ulna kind of spreading apart. Kind of that gapping, that's a word you hear a lot in the orthopedic side of medicine, the kind of the gapping of the elbow. This is kind of what that represents. So as you can probably infer, so with that gapping, we're going to have an increased demand of that ulnar collateral ligament. So as this space increases, it's kind of getting stretched and stretched and stretched. So as we increase that carrying angle in this representation, you can kind of infer that the UCL is going to be undergoing more and more stress. So that's cause for potential for injury. So now to kind of bring it all together, connect the dots. So going back to the PRI side of things that we started with when we started talking about the elbow, the left scap being a more external rotation orientation relative to the right. You can kind of see this in this picture. Not super well, although not super well because of the arrows drawn on top of the left scapula, but this right scapula is a little more winged off. That medial border is a little more flared off relative to the left. The left medial border is a little more pressed up against that posterior rib cage. So it's already kind of started in that position due to the right BC, left AIC, right BC influence, and then it kind of got superimposed with the demands of throwing. So it's even in even more external rotation than it would be without being a thrower. And then the humerus is kind of following that in the external rotation, and then going all the way down the forearm. So when we're throwing at that moment of deceleration, we have that abrupt moment of pronation happening at the forearm and the wrist. This is indicated, although not a great example here, this picture either, of the forearm kind of folded inwards relative to the humerus. And you can see, although you can't really see on this picture, but the left wrist is more folded in on the left side than the right. So that's indicative of more pronation of that left forearm relative to the right. So with those things, so connecting it to the previous slide, we have more external rotation of the humerus, more pronation at the forearm, which, as we talked about in extension, that's going to gap this medial elbow a little bit more, and in turn impart more stress on that ulnar collateral ligament UCL, which is why it eventually, over time would sprain. It's being stretched out constantly, and eventually did end up tearing. All right, so looking at mechanics, we're going to kind of connect the dots between some of the things that we've talked about previously and applying them to my mechanics and why some of these patterns and movements may have contributed to injury. So the first thing we're going to look at here, we're going to look at this postural picture here that we looked at previously. We talked about this right thoracic side bend that's going on. We're kind of side bent to my right side. And this is indicative of a lack of left, what's called ZOA, so zone of apposition. So the inability of these left side abdominals to sort of oppose that left diaphragm. So this is an inability of that left side to stay active through those left side abdominals. This is kind of also because of that. We talked about the left side ribs being externally rotated, so we need those left side abdominals to bring those ribs down. If we don't have them, then that left side is kind of be unopposed, and it's not going to be, you're not going to be able to stay into that left side as well. It's going to kind of fly open, especially as related to mechanics. So inability to stay into the left side. We kind of see this happening as I'm diving my center of mass forward in the delivery here. So the inability to maintain these left side abdominals manifested itself kind of in the still frame mechanics. Not great quality here, but kind of you can see that the thing we're going for here. You can see the head kind of right over the right pelvis, right side of the pelvis here, instead of staying stacked right over where my belt buckle would be. So this could definitely be an inefficiency. If we're diving forward with the center of mass, we're kind of leaving the arm behind. We're kind of just leaking energy forward. We're not really able to use that yet, because once the front foot hits, instead of being in a stacked position, we're already way out forward, and now that energy has kind of already been wasted as that front foot hits, and we're trying to send energy back up the chain. So circling all the way back to the beginning structural part of the presentation, the narrow ISA, so initially biased towards external rotation, then you kind of add in sort of the stuff that goes on with the left AIC pattern. So we have the supination or ER of the right tibia happening here. So we're favoring, every human's going to favor their right side with the sacrum pointing to the right, bigger right diaphragm, some brain asymmetries as well. We're all going to be lateralized to the right. So this is going to have supination on the right foot because we're kind of leaning towards the outside of that right foot. And you can kind of see this supination happening at the tibia, the ER of the tibia, and the supination happening at the foot here as this foot lands in the what's trying to be a lead leg block, but not really. You can see the ER, the amount of ER at the tibia and the foot here as I land. So I'm landing pretty much wide open, very inefficient lead leg block. Like I said, landing open and shin bowing out. We're not able to really stop this segment of the delivery, isn't really able to stop the energy and send it back up the chain. A lot of leaks, we're only sending a little bit up. So I separate pretty well here, got a lot of rotational energy coming through, but since that lead leg isn't able to block and efficiently stop this pelvis from rotating and send everything back up the chain in the ball release, instead we're spinning off, only a little bit of the energy is being transferred back up the chain. So, and then my arm has to do a lot of the decelerating. So since the pelvis isn't really decelerating, it's just kind of spinning off, the arm kind of has to handle all the deceleration itself as it comes through, just because the lower body here is just spinning off in the rotation. It's not actually stopping any energy or decelerating the body. So continuing further with the lead leg block, we're going to look at some dynamic examples, so some videos of me kind of going through this. This first one, I'm around, I think it was 4th grade, so right around the time where I that arm pain kind of started. So let's play this through. You can see me just kind of spinning off, no real block happening. Now obviously, like, you don't expect a 4th grader to have a perfect lead leg block, but that could have contributed to kind of the arm pain I was feeling at the time. That arm's going to do a lot of the decelerating itself. Always had a pretty fast arm, so probably already had that predisposition to higher stresses on my arm. Then you add in some inefficiencies, and that's when you get possibly some injuries. And then a little bit older here, this is senior year of high school. Kind of watch that front leg, see it kind of bow out, doesn't really block, pelvis just kind of spins off. Arm is doing really all the decelerating here. We'll watch that one more time. Just pay attention to that front leg, that tibia bow out into external rotation. Same with the foot. The foot's kind of pointed towards where the third base dugout would be. So we kind of already talked about the consequences of the inefficient block, and then kind of connecting it to the bicep pain that I've kind of had on and off throughout my career. When the arm has to handle the bulk of the deceleration stress on its own, that could be a reason why that bicep's always pretty fired up and inflamed. And also kind of connecting the dots to something else too, when that humerus is in more external rotation, like we talked about with the structural predispositions and the demands from throwing, that bicep may be in a position where it accumulates even more stress and it gets even more inflamed and some more pain. So this is more theory than anything. This isn't really backed up by anything, but it's just kind of me thinking things through, trying to reason through why certain injuries happen. Looking at the timing of the arm and the front foot plant, and this is something that's been studied pretty intensively in the literature, and there's pretty clear-cut correlation between having a late arm and then increased stresses on the arm and then increased stress to injury as well. So having a late arm, so when this front foot gets down, where is the arm at? My arm right here is around 0 degrees on this still frame image. On time would be anywhere between like 45 and 90 degrees. And like the exact degree doesn't really matter too much. You'll see guys occasionally who can get away with having later arm action and still being healthy, but I'd say for the most part, most healthy pitchers are between that 45 and 90 degree mark. And the reason why this is an issue is the scapula and the shoulder are not in a position to accept those rotational forces as we go into layback. So instead of working together as we kind of start going into external rotation and layback, the elbow is kind of on its own until the shoulder is in a position to have leverage to fire. So as we look at kind of the consequences of this still frame throughout the throw, we'll see a little bit further. This is kind of when we're fully flipped up here, and you can see the upper body is pretty much not done rotating, but it's already well into its rotation. So the arm's kind of hung out to dry here as the trunk rotates a little bit early. And as we go through, that elbow is going to push out a little bit in front of the face as well, which is another vulnerable position because it's not being supported by other structures. When this is happening, the layback's happening more out in front of the face, you lose the leverage of bigger muscles like the pecs and the lats and the rotator cuff and things of that nature that kind of help protect that UCL, resist those valgus stress, and kind of assist in that external rotation instead of that UCL kind of being on its own, trying to resist those forces. So when it is on its own in that vulnerable position, that's where we see increased stress on that elbow, and most of the time maybe it's not able to handle it. It'll either sprain, it'll be overly stretched, or it'll tear. So now going into some more lower body stuff. So kind of the thing throughout my high school career is everyone was talking about the hinge. Everyone's got a hinge. You got a hinge to be in a powerful position. You got a hinge to be able to rotate, all this stuff. So me listening to this, I'm thinking, all right, I got a hinge. So I'm going to shift the hips back. And what this really turned into was me just dumping the pelvis forward and extending. So you can kind of see this lower back extending here. The hips, if you were to draw a line, kind of the line of the pelvis would be something like this. And kind of if you remember the previous slides and in the beginning of the presentation, I was someone who's very extended, like that large curve, my low back, pelvis is already dumped forward. So I'm already someone who's predisposed to that orientation. And why that's a problem is, at least in this context, extension is going to lock up rotation. So if I'm extended through my low back, extended through my neck, I'm not going to be able to rotate. I'm also not going to be able to like use muscles like the hamstrings and glutes. They lose all their leverage when you're extending, you're dumping your pelvis forward. You're not going to be as powerful in that position. You're not going to be able to dissociate and sequence properly because you're going to have to wait until these hips get back underneath you to start your hip rotation, and that's going to cause some things down the chain to be an issue. Like your arm's probably going to be late because it's going to wait until these hips get back under you until they rotate, and there's going to be some timing things thrown off later in the delivery. You're also going to lose, like I said, rotational power by not being able to leverage the hamstrings and glutes. This is a great example of what you should be trying to do rather. I guarantee he's not really thinking hinge because his knee's out in front of his toes. Not that it matters, but this is kind of a bad position in some people's eyes. But you see his hips are underneath him. They're right underneath him. He kind of has almost the opposite of what I have here. I have this angle, this extension. He has this flexion going on throughout his low back. This is a really powerful position. I think this pitch is around 96, 97. This is Travis Sikora. This is him. He was probably like 17 in that picture. I think he just got drafted. But this is what is more efficient, more powerful. This is what is not, and can cause some more timing issues as well as losing power and efficiency throughout the delivery. All right, so kind of going through an example with the delivery. Now, obviously, there are more differences between me and Aroldis Chapman than just mechanics, but kind of giving a contrast example here. So going through my mechanics here on the left. So we start stacked as we pull that leg lift up. We're in a good position here. Hips are under me. And I'm thinking, oh shoot, I got a hinge. So I shoot those hips out. See right about there, that low back starts to extend as I work my way down the mound. Front foot gets down right about, I would say there, give or take, right about there, maybe a frame later there. Either way, the hips aren't really open. The arms laid either way. The hips really don't open until right about there, and by that time, the upper body is started to rotate as well. So we're not seeing a good amount of dissociation or separation between the upper and lower body. So the hips are extended here, not able to rotate. They finally get back under me here as they start to rotate, and that's kind of when the arm flips up as well. So we kind of see the connection between those two things, the hips rotating as well as the arm flipping up. So when those hips start to rotate and they're fully open, usually the arm's up as well. So when one is late, usually the other is late as well. So kind of what you would want to look like. Chapman here, he goes into peak leg lift. His hips get under him, they stay under him. Now, obviously, there's an amount of requisite strength in order to pull that off, like to be able to keep the hips under you as you move down the mound. It does require a good amount of strength, and that could have been a contributing factor to why I couldn't do it in this. But I also think it was just that internal cueing and constantly being told and seeing all over the internet, you need to be able to hinge to throw harder and to throw more efficiently. So we kind of see that cascade of effects of me dumping my pelvis forward, that lower back extending, causing things later in the delivery to be an issue, and then increasing stress and not being as efficient and as powerful as moving like someone like Chapman. So to compile everything together and kind of take everything we've been talking about and put into like what I would do differently if I were to do it all over again. Some of the different things I would focus on and maybe not focus on as much. So when it comes to structure and range of motion, I would focus more on gaining and maintaining internal rotation when it comes to the hips and the shoulders. My left hip would get pretty stiff in internal rotation. I felt like that would limit me from being able to rotate my hips. So when I felt like I had good internal rotation there, I was able to rotate a little bit better. But then a huge emphasis on maintaining the left internal rotation of the shoulder. I kind of noticed this looking back, but when I was stiff in internal rotation, usually that's when my elbow would start to act up secondary to that. So I would put a huge emphasis on getting air into my chest, kind of being able to expand anterior to posterior. Like I said in the very beginning, doing that through getting facilitation of the internal obliques, external obliques, and transversus abdominis to internally rotate this rib cage, sort of decrease that volume in the lower part of the thoracic cavity to be able to generate air upwards and into the chest, to be able to expand into the chest to improve that left internal rotation. Because I feel like when that internal rotation was good, that was indicative of my humerus being in less of a externally rotated orientation. And when that humerus is in less external rotation, there'll be less gapping at the elbow, was kind of my train of thought thinking through it. So transitioning out of that, left stance and left DOA focus. So being able to own the left stance, so having what's called AFIR on the left side, so having the acetabulum internally rotate on the femur on the left side, then the left ZOA, so those left side abs, kind of what I talked about just previously with having those abs being able to close and internally rotate the rib cage. And that would be being able to own left stance would, I think, really help me from diving my center mass forward. You saw in a lot of those videos, kind of my trunk would get ahead of everything. My arms kind of behind, kind of lagging behind. If I was able to own left stance, stay in left stance, stay closed longer, I feel like I would be able to sequence a lot better and be able to not lose as much energy as my center mass dives forward. And then going to the next one, right tibial internal rotation work to minimize building of the front leg. I feel like this kind of would have been cleaned up a little bit with some of the stuff. So if I was able to own left stance better and I wasn't diving forward, that front leg maybe wouldn't swing open as much as it would, and I wouldn't land as open. But obviously, like working deliberately like on internal rotation of the tibia would have also been advantageous. So I land more square. I'm able to really stick that landing so that foot gets down. It's not bowing out and spinning out. It's able to land, stick, and then send energy right up the chain. So these are some structure things that I would focus on. Just some ranges of motions and things that would hopefully minimize injury as well as increase performance. from a weight room training perspective, so after I built that initial base of strength, sort of my freshman and sophomore year of high school, I transitioned more to unilateral lifts to be able to maintain relative motions. I think those big bilateral lifts were useful up to a certain extent, and then the return on investment really wasn't there anymore. I could have still pushed strength and power in different exercises like split squat, single arm bench, single arm row, and other unilateral lifts. Push power and strength while not sacrificing the range of motion at the same time, not having to trade one for the other, being able to build both kind of simultaneously, or at least maintain range of motion instead of sacrificing it. So then maintaining speed with consistent jumping and sprinting. I feel like I kind of got away from this. Being athletic is something that would be a huge emphasis if I were to do it over again. I feel like I kind of got robotic. I think a lot of people who turn into pitcher onlys at an early age can get pretty robotic, and they can lose a bit of the athleticism, the thing that made them, special in the first place. They end up kind of losing that. So jumping and sprinting, kind of maintaining that twitch, that fast twitch ability, and kind of that variability of movement, being able to self-organize in space, and just having the body figure things out for itself. I feel like I lost some of that and tried to internally cue too much and started thinking about every movement. And then mix in some aerobic work as well. I think as pitchers, it's really easy to think, well, I'm the work that I do is super short bursts. Everything I do in the weight room should be quick and powerful, with rest in between. And there is some truth to that. It is a primarily anaerobic activity, but I think mixing in aerobic work has its place in that the more anaerobic, the more you build your the more you build your aerobic capacity, you're going to see things like your resting heart rate and things like that start to go down. You're able to access more of that parasympathetic nervous system easier, if you were to focus more on aerobic work than just focusing on anaerobic work. So this kind of goes into what I talked about with the extension part of my mechanics. When we're stuck in this sympathetic fight or flight state, our body is in global extension. We're constantly in fight or flight, trying to detect threats. We're extended. But if we're able to access more of a parasympathetic state, and I think doing this through aerobic work and kind of drive that heart rate down, being able to basically breathe less, lower the respiratory rate as well, being able to access that parasympathetic state a little bit more effectively, and that would help in turn with things like recovery and things like that. So I think this is generally covers basically everything I would change in the weight room, or maybe do less of. But overall, I think other than what I did with the heavy bilateral lifting my junior year of high school, there really wouldn't be too much I would change. I was very fortunate to be able to work with Josh Owen starting my junior year of high school, and he's one of the best in the business when it comes to strength conditioning, and his programs were always on the money for me and my needs. So there really wouldn't be too much I would change in that aspect. With mechanics, so the first thing, I would not have cued hinging for someone like me. I would think instead to keep my hips more underneath me. As someone who's already more extended and has that anterior orientation at the pelvis, I think hinging just further drove that, and then ended up locking me up into extension and caused some timing issues down the road. Then I would carry over some of that left COA work into my patterning work, so staying stacked, head in line with the belt buckle, not diving forward. I think hammering that with like corrective drills and managing that through PRI type drills, being able to feel what it's like to have those left side abs on, would just carry over in itself to throwing. I don't think I'd really have to think about it too much, and hopefully not. And then emphasis on timing of the arm, having a huge emphasis on getting the arm up at front foot plant, whatever it took, whether it was some type of external cue or some type of, I don't know, any type of drill really, just that to help me feel what it was like to have that arm up at front foot plant and to be able to carry that into throwing and have that chain stick. And then working on the leg block, kind of something I talked about too in the what I would do differently structurally and range of motion wise. The tibial internal rotation work, having a huge emphasis on landing square and staying square, kind of folding down, feeling like that front leg super strong and send everything back up the chain, not having it spin off. And then throwing down the mound more, I felt like I got into a mode where I was throwing a lot of flat ground, and my mechanics felt great on flat ground, and the ball was coming out well on flat ground. But then when I get down the slope, things changed a lot, and I wouldn't be as efficient, and some things broke down. So I just think getting more reps in the mound, getting more feedback on the mound would have been advantageous. And then just being athletic, not thinking as much, being being as robotic in my mechanics. There's a time and a place for that. I think during some developmental periods in the off season, there's times to feel things out, but knowing when to shut that off and when just going into compete mode and letting the athlete in you take over is very important as well. So what I would do differently from the mental side, and this part should not be underscored. This is as important, I think, probably as anything throughout the whole presentation. So first and foremost, knowing how to flip the switch between practice and compete mode. There's a time and a place for when you're like tinkering with some new mechanical feel to feel certain things out and maybe think about some things. But when it comes to compete or anything resembling a competition, all that needs to be thrown to the wayside. It's just about imposing your will on the opponent and just doing whatever it takes to win. So then using external cueing as much as possible and minimizing internal cueing. So minimizing the stuff that's thinking about, okay, I want to put my body in this position, like literally thinking, okay, I want to shift my left hip back, or I want to land a certain way with my front leg, and putting my body in a position to do that in itself, whether it's constraints, so having something lined up to the side of me where I'm not able to open my front leg as much as I usually do, so I have to land more straight on. I would use that instead of thinking myself, okay, this is how I want to land with my leg. So I would use external cues and constraints versus internal cues, because I think those internal cues can really bog you down, because you don't want to be in a competition mode and having to think about how your front leg is landing. You just want to be able to do it. And I feel like when you're able to do it through an external constraint, you're able to feel that, your body's going to be able to replicate that easier without having the guardrails of having to think about what you're doing. And the last thing would just be confidence. I think there's a great quote, I don't know who said it, but confidence and self-belief precedes action. So you believe in yourself before you're actually able to accomplish whatever it is you want to accomplish. And I would just say that, and noticing this a lot in college baseball, there's a lot of people who do not have maybe the A stuff or even B stuff, but they just have this almost delusional level of confidence with the stuff that they have, that they're just going to get hitters out, and they just shove it down guys' throats, fill up the zone, and they get out. So it's just the way it is. Like guys who take the mound with some type of confidence and aren't scared of the results usually end up having better results. That's something I would take as well. All right, so if you're still with me after all that, thank you. This is basically the last slide to kind of wrap things up. Anything that I can expand on, or anything you guys may have a different opinion on, please let me know in the comments or reach out to me directly. I mean, the ultimate goal of this is for me to not only increase my own skills and knowledge of this field, but also to be able to help as many people as possible. So anything that's going to help me do that, please feel free to reach out. Thanks again for watching, and stay tuned for some future content.